Thank you very much for the invitation to contribute to this very important session. These are my disclosures. They have not affected what I'm going to say in the next 20 minutes. Sepsis is obviously a very common problem, and all of us will be asked to look after patients with sepsis, either in the intensive care unit or outside. And we're encouraged to treat patients according to the surviving sepsis guidelines. The last version was published last year, and it's the third revision based on data up to 2016. It's a large document containing 93 recommendations, of which some are strong and others are weaker. 18 recommendations are just practice statements based on common sense and expert consensus opinion in situations where evidence is missing. As we said by Professor Kellum, at the heart of sepsis management is source control. It is essential to identify the cause of sepsis, to be sure there is no localized infection in an anatomical space, and to deal with this and manage it by draining it or implementing a surgical intervention. This is complemented by antibiotics, and according to the surviving sepsis guidelines, we're encouraged to give antibiotics within 1 hour. And Professor Kellum elegantly showed that timing of antibiotics is crucial. The guidelines also remind us to give broad-spectrum antibiotics. And this recommendation is based on the fact that several studies have shown an increase in mortality in patients who had inappropriate antibiotic treatment. And inappropriate means either not broad enough or not long enough or not including all the potential bugs. As you can see here, where you have several different studies, patients who received inappropriate antibiotics in these black columns had a significantly higher hospital mortality compared to those who received appropriate antibiotics. In order to prescribe appropriate antibiotics, the recommendation is to go broad in the beginning and then tailor down and de-escalate according to the antibiotic stewardship recommendations. Following on from antibiotics and source control, we come to fluid and hemodynamic resuscitation. Now, clearly, this is an important component because most patients with severe sepsis will be hemodynamically unstable and will suffer from often from vasoplegia and increased vascular permeability. They're often intravascularly volume deplete and may need some fluids. The current recommendation suggests to give 30 mL per kilo of intravenous crystalloid of any type within the first 3 hours. And we're reminded to reassess the situation regularly and continuously and to continue with fluid prescription as required. With regards to the types, as I said, the recommendation only includes crystalloids but no particular type. But there is a clear warning against starches. Although the recommendation or the surviving sepsis guidelines highlight the need to do regular assessments and to individualize the therapy, the official guideline have a prescription of 30 mL per kilo per hour, and it is likely that this will change with a new iteration. And that's because we all now know that there's a very high risk of fluid overload, and there's an increasing awareness that fluid overload is actually harmful. And as such, we are asked to reassess the situation regularly using dynamic tests, checking the fluid responsiveness in response to maneuvers, for instance, straight leg raising. And this is necessary so that we don't miss the point where fluid resuscitation is no longer required and in fact should be discontinued in order to avoid fluid overload. This is has been illustrated in numerous recent publications, but was also a focus of an ADCI meeting a few years ago. And the group at the time looked at the resuscitation period in more detail and essentially divided into multiple different phases. And if you do this, you would probably agree with me, there is a period right in the beginning where patients are very, very sick, under-resuscitated, and where resuscitation and rescue, initiation of life-saving therapies is the key. This is at the heart of what we want to do. During this time, clearly, some fluid resuscitation is often needed. This is followed by a period of stabilization and optimization. And then once patients are stable, we're encouraged to quickly move to de-escalation, where we tailor things down, where we de-escalate antibiotics and also focus away from fluid resuscitation to maybe fluid de-resuscitation, fluid removal. If you look at fluid status during these particular periods, then you can see during the rescue phase, it may be acceptable to accept a small amount of fluid overload, provided this stabilizes quickly and is followed by a period of fluid removal. As Professor Kelly-Morey said, this is all very important and is essential to avoid harm from fluid over-resuscitation. The problem is obviously recognizing when to stop fluid resuscitation and, in fact, when to switch to de-escalation. Fluid management is often combined with vasoactive therapy in the form of vasopressors. The surviving sepsis guidelines recommend to use noradrenaline as the first-line vasopressor, and they suggest to aim for a mean arterial blood pressure of 65. Now, this target is based on several retrospective studies which showed that a mean arterial blood pressure of 65 was associated with a better outcome. And it also showed that a higher blood pressure did not translate into any more or into better outcomes, and in fact was associated with harm from vasopressors. This recommendation is also supported by a randomized controlled trial conducted in France, where patients with septic shock were randomized to two different blood pressure targets. So 65 to 70 versus 80 to 85. The patients enrolled in the study achieved these blood pressure targets as shown here. There was a clear separation between the two groups. But with regards to mortality, there was absolutely no difference at 28 days and 90 days. So aiming for a higher blood pressure with the obvious intention to improve organ perfusion does not translate into better outcomes. In a subgroup analysis, it became clear that, again, patients are individuals and should be treated accordingly. In this sub-analysis, patients with chronic hypertension, so those who were used to a higher blood pressure, had a significantly lower need or risk of needing renal replacement therapy if they were randomized to the higher blood pressure group. Again, although it's a sub-analysis, it's a reminder to treat people individually according to their comorbidities and their needs, their medical needs. As I've already said, the guidelines recommend to use noradrenaline as the first-line vasopressor, and they suggest vasopressin or adrenaline as adjuncts in cases where noradrenaline is not sufficient to meet the target. Again, there's a strong reminder to reassess the patient regularly, and in particular in situations where shock does not resolve. Now, if shock doesn't resolve, there may be many reasons. It may be that the first principle has not been fulfilled, that source control has not happened. There may also be other contributing factors which should be excluded and should be looked out for. Maybe a cardiac problems, maybe pericardial problems. It may be a hormonal problem. And this brings us straight on to the steroids. Now, steroids have been the focus of investigations for many, many years. And the current recommendation is not to use steroids routinely in patients with septic shock or severe sepsis. The guidelines recommend to consider steroids in situations where fluid and hemodynamic support is not sufficient. And in these cases, they suggest to try hydrocortisone at 200 milligrams per day. As we've already heard, since then, the results of 2 major trials have been published, and it's very likely that this particular recommendation will change with a new iteration of the guidelines. We've just seen the results of the adrenal study, which was a randomized controlled trial, hydrocortisone versus placebo, and it was entirely negative with regards to the primary outcome. But some people feel it's still a very important study, in particular when you look at the secondary outcomes, where clearly there was a difference in very important patient-centered outcomes, for instance, resolution of shock, discharge from the intensive care unit, or need for blood transfusions. We've also just seen the results of the French study, looking at hydrocortisone in combination with fludrocortisone versus placebo. And as we heard, this was a positive study with a significant difference in 90-day mortality. Clinical practice is already changing, but at the moment it's still very variable, and some people are adopting these results, whereas others are waiting for the official recommendation by the Surviving Sepsis campaign. The next important component is renal replacement therapy. And that's clearly an important component because this is a high-risk group at high risk of acute kidney injury. In fact, sepsis is one of the most common causes of acute kidney injury in the intensive care unit, and a large number of patients need renal replacement therapy. With regards to the official guidelines, they are very vague. You will all agree with me, timing of renal replacement therapy is a very controversial area, and we still don't really know the optimal time for initiation of renal replacement therapy. This is replicated in the guideline here, where the guidelines committee felt that renal replacement therapy has a role and needed to be considered, but it should never be based on a serum creatinine or urine output alone. With regards to the optimal modality, they felt there was no evidence to suggest one or the other, but acknowledged that fluid removal was easier with a continuous modality, and that a continuous modality had advantages in patients who were hemodynamically unstable. Lastly, a few adjunctive areas. So this is nutrition. Nutrition has been an important area of research for many years. Some people have looked at different types of nutrition, including immuno-rich and various different types of nutrition enforced with vitamins or other elements. With regards to the guideline itself, the committee felt there was no clear evidence to recommend a particular type of nutrition. Standard enteral nutrition was sufficient, and there was enough evidence to recommend enteral nutrition early. They acknowledged that some patients may need parenteral nutrition, but only after enteral nutrition had failed or was insufficient. And lastly, they also looked at adjuncts like intravenous immunoglobulins and erythropoietin, and felt there was insufficient evidence to recommend them. As John has already said, previous versions of the guidelines included clear targets. We were encouraged to aim for a particular central venous oxygen saturation, a particular lactate. These targets are no longer included, and it is acknowledged and has been recognized that not everybody needs to have central venous oxygen saturation measured. But these are tools which we may need to guide our treatment and to manipulate and maneuver our treatment according to the individual needs of the patients. So in conclusion, the most important components of sepsis care remain timely source control, in addition with rapid administration of the right antibiotics, combined with fluid resuscitation and vasoactive therapies in order to overcome intravascular volume depletion without causing fluid overload. And there's an increasing recognition that we need to adopt an individualized approach with consideration of the individual patient's needs. And I hope that this will be incorporated in the next version of the Surviving Sepsis Guideline. Thank you very much.